thank you all so much for being here. My name is Sarah Steenhausen. I am Director of Policy and Advocacy for the SCAN Foundation, and really honored to moderate today's discussion. But before we get started, I want to introduce Rigo Saborio, who is President and CEO of St. Barnabas Senior Services, and also the esteemed chair of the LAAAC Advocacy Coalition. Rigo will provide us with some welcoming remarks, and then we will take it from there. Thank you, Rigo.
Thank you so much, Sarah. It's a pleasure to be with all of you this morning. I want to welcome all of you to the 11th Annual Aging Summit. The summit is brought to you by the Los Angeles Aging Advocacy Coalition. As you've heard, my name is Rigo Saborio, and I am the chair of LAAAC, but also one of the 3 co-founders of this entity. And as many of as you know, the Los Angeles Aging Advocacy Coalition was founded a little over a decade ago by Ultimate Health Services Corporation, Partners in Care Foundation, and St. Barnabas Senior Services to bring together consumer advocacy groups, aging service organizations, and other key allies in LA County and beyond to be the united voice for older adults, family caregivers, people with disabilities, and organizations serving and or advocating on behalf of older adults. Since then, its membership has grown to over 60 organizations and countless number of advocates representing well over 1.5 million older adults in the Los Angeles region. Since its founding, LAAAC has impacted the aging landscape, playing a critical role in shaping city and county policy and budgetary decisions, and has also been a strong partner at the state level as well. And after COVID, that prevented us from getting together last year at our planned annual summit, we're back. But until we can all come back together safely, we move forward virtually. So that said, the summit this year is taking place over a series of 4 sessions every Thursday this month of October, focusing on the California Master's Plan for Aging, which has 5 bold goals: housing for all stages and ages, health reimagined, caregiving that works, affording aging, and inclusion and equity, which will be woven into each of the 4 sessions that we will be focusing on. And last week, we kicked things off focusing on caregiving that works. And so as many of you know, the Master Plan for Aging in California was unveiled earlier this year, January 2021, by Governor Newsom, which includes goals and initiatives that state and local governments will and are now undertaking to make California more age and disability friendly for all, and to prepare for the expected growth in California's 60+ population to 10.8 million by 2030. The plan resulted from a collaborative effort involving a range of stakeholders and state agencies led by CDA's former director, Kim McCoy-Wade, who is now the newly appointed Senior Advisor on Aging, Disability, and Alzheimer's for the Office of Governor Gavin Newsom. I had the good fortune to serve on this committee and to work in the process very closely with our very own esteemed moderator for today's summit, Sarah Steenhausen. And I have to tell you, Sarah's fingerprints are all over the plan. I could speak from experience. She won't tell you that, but I will definitely say that. She provided immensely valuable input and significant work into it. And we, all Californians, are the better for it. So I am so thrilled that she's here today to moderate the session, which we are focusing on healthcare reimagined. While we are here today to focus on the Master Plan on Aging and what steps we can take in LA County to implement it, it's important for us all to know that the Master Plan doesn't exist in a vacuum. There are numerous and significant factors that will impact the healthcare and supportive services that so many of our older adults rely on here in Los Angeles County. I'm not going to go into depth on each of these now, but just to give you a sense of scope, I'll note that CalAIM is the state's effort to completely redesign how the state's Medi-Cal program will serve the over 12 million residents who get their health care through the program. And the Home and Community-Based Services Spending Plan is the state's plan for spending approximately $3 billion in federal dollars, impacting a wide range of programs from IHSS to senior nutrition and beyond. In addition, There are initiatives and changes happening here in Los Angeles, such as Purposeful Aging, LA, and the creation of a standalone county department of aging that will also play a role in how things unfold. It is within this larger context that we will need to consider what we advocate for from the master plan. And this morning, we have the pleasure from hearing from Supervisor Holly Mitchell on her thoughts on Health Reimagined for Angelenos. And I am going to, Sarah is going to actually do the introductions. But we're very fortunate, and I want to personally just say thank you, Supervisor Mitchell, for making the time to be with us today. We are really looking forward to hearing your thoughts on how we reimagine healthcare in Los Angeles County. Let me also say that LAAAC's advocacy effort will play a critical role in ensuring that the county moves forward with the Master Plan on Aging's implementation in a way that best meets the needs of older adults. How we decide our advocacy priorities among all of these options, and we must be clear on what our community needs, what initiatives and ideas have momentum, what's within the LA County's ability to implement or influence, and finally, and most importantly, what moves our community closer to closing the persistent health inequities. So with that, I'm going to now turn it back over to our esteemed moderator this morning, Sarah Steenhausen. And Sarah, you can take it from here. Thank you so much.
Thank you so much, Rigo. What a wonderful overview and introduction to set the context for our discussion today. And I just want to say a tremendous welcome to Supervisor Holly Mitchell, who was elected in November 2020 to serve as supervisor to the 2nd District of LA County. And Supervisor Mitchell, it's such an honor for me to be here with you because I remember way back in 2000, I think it was 2001, when you were an advocate for Western Center Law and Poverty. And I remember meeting you in the Office of Health and Human Services, then the Senate Health and Human Services, when you were when I was a Senate fellow. So to see your career emerge from Western Center Law and Poverty to serving in the Assembly for 3 years, and then 7 years as a state senator, to be the distinction of being the first African American to serve as chair of the Senate Budget and Fiscal Review Committee. It's pretty amazing what you have done and the tremendous difference that you are making for all individuals in the state of California. I just want to highlight that in your work at the state and local levels, you've done a lot to be at the forefront of expanding healthcare access, addressing systemic racism, and championing criminal justice reform. And I think all of these issues, something about aging is that it's not really isolated in a silo. Aging impacts all areas of society. So I think that your perspective and your experience as a policymaker is really valuable to all of us today. And we're so fortunate to have you here with us and look forward to your reflections on opportunities and challenges regarding the intersection of aging and health equity. But before you begin, I just want to let the audience know that we would love to hear from you. So please use your chat function to type in your questions. We're hoping that Supervisor Mitchell can stay for just a little bit and answer a few questions. If you can't, we understand, but we will take any time that we can. And then after you leave, we will have a wonderful esteemed panel that will kind of provide some insight and thoughts on the analysis that you provide us. So welcome, Supervisor Mitchell.
Sarah, thank you very much for that generous introduction and that amazing walk down memory lane. When I was lobbying for the Western Center, and the reason I was probably hanging out in the Senate Health Committee is because, I was former staff back when the committee was Senate Health and Human Services Committee. So those committee offices were often my kind of landing space because many of the consultants I had personal history with, we had been colleagues. So thank you for that. And, it's that history, my personal professional history, that has really kind of influenced the populations that I have focused on and served really my entire professional career, from working for Diane Watson as chair of the Senate Health and Human Services Committee, to lobbying for the Western Center, for being the ED of the California Black Women's Health Project, then to Crystal Stairs. Again, really my whole career serving the same population of hardly reached Angelenos and Californians who are entitled to government's focused attention and support to help them grow old with dignity and raise their children in a community in which they can thrive. So thank you, Sarah, I appreciate it. And thank you, Rigo, and thank you for that great visual that helps people connect the state budget to all of that work, and then how it then comes down to us now at the county level, where it's our opportunity and responsibility to make sure that we are pushing out programs that work. So thank you. You don't have to tip my hat. I had so many colleagues in the legislature, and the first one who comes to mind is former Assemblywoman Cheryl Brown, who would come to the Legislative Black Caucus and bang her fist and talk about the grain of California. And so for California to now have a master plan for aging is great. And for LA County to have made the decision, I hear the voice of my colleague, Supervisor Hahn, most prominently talk about how ridiculous it was that we kind of had this one department that felt to me like a catch-all. It was, workforce development and aging, like the and aging was a tag on at the end. So, we have now separated those two. Just went through the process of making a decision on hiring the person who will now lead WEDAX, the workforce development. And our next assignment as a board is to place the person who will be in charge of the new Department on Aging. So I think it's a great thing. You all know these statistics better than I, but it really is, sobering when we recognize that, 11% of LA County's population are older adults, expected to be over 2 million by the year 2030. When we recognize that the GAO estimates that about 16 million people age 60 and older will likely need home-based services in the foreseeable future. When we recognize that 60% of the senior population in LA County are people of color, and how government must work collaboratively with community-based organizations and organizations like LAAAC to really meet the needs. I have two personal sister friends, Carlene Davis, here in LA, who have founded an organization, Sisters Aging with Grace, SAGE. And they just issued a report that I was able to read and review and provide the forward on, that really talked about the importance of listening and mobilizing government to meet the needs of this growing population, but to listen to those needs. And that is something we certainly do here in my office, and work very hard to make sure that government is indeed responsive. Just a few things, just so people know ways in which we can use the budget process, which is kind of where I have spent my career focused on, to really deliver meaningful services and resources back to my community, and what we've been able to do here at the county. So, we've made some historic investments in this year's Care First Jail's last budget. And these are just a few examples. Additional personnel in the Adult Protective Services Department. We have heard over the years about, because of high caseloads, their inability to truly protect senior vulnerable adults. And so additional resources for personnel, I think, is key. That's an area of government where people love to tinker with and trim the fat, but it's people who provide government services. And so when we cut back on those budgets and cut back on those FTEs, it has a direct impact on the quality and caliber and amount of service that can be provided. And so I always lean in when people want to talk about cutting personnel. When we cut personnel, we're cutting services. And adult protective services, that could be a matter of life or death. So I'm glad that we've added personnel. We've increased funding to prevent seniors from really falling into homelessness by including $7 million for permanent supportive housing targeting seniors. The Elder Nutrition Program, recognizing food insecurity, additional funding. And we're investing in what you heard earlier in Purposeful Aging Los Angeles, the LA City and County Partnership Initiative. I have great hope for this initiative. I think it will be wonderful And again, a perfect opportunity for the city and county to come together and create a joint combined effort to really support our shared constituency of aging Angelenos. You know, during COVID and our effort to provide resources to Angelenos, I heard loud and clear from one of my appointees to a county commission focusing on issues for our senior population. And that was homebound vaccinations, recognizing that our seniors are living in a variety of different kind of housing constellations, if you will, from SNFs to shared housing to quite a number who are still living independently, but unfortunately sometimes in isolation. And so uplifting and getting our homebound vaccinations program was really important. What's also important is we're looking at expanding our Promotortis program, and the beauty and value of the Promotortis model is knowing that we are going old school, door to door, to understand, to see people. I see you, Ms. Jones, and I know that you are living here alone. And what can I do to bring information to you and resources that are relevant to your unique needs? You know, I think government understood the value of our community partners who have done this for years. I did it at the California Black Women's Health Project. We partnered with Promotortis and had our own model of a Promotortis program, where it really is that very grassroots community, one by one, each one reach one kind of model. And so expanding our Promotortis, and it is my hope, I know Secretary Richardson at the state level has made the commitment that we just don't provide these grant funding to the nonprofits when we're in the middle of a crisis, but that we continue to provide supports to these organizations so they can continue this door-to-door outreach. Because, you know, after COVID vaccinations, it's going to be something else. We're going to need to encourage people to get their flu vaccines. We're going to need to encourage people to do whatever the case may be. So it's bringing information to seniors where they can receive it. So we're going to continue to provide support and expand that funding. And of course, I already talked about separating WEDAX into 2 departments. I'm very proud about that. So those are some concrete examples of ways in which through the budget process this year, we have acknowledged the needs of our seniors, are anticipating growing and different needs for our seniors. And, you know, it's always my goal to try to be in front of the situation, as opposed to a typical government response, which is to be responsive and late to the party. I have a very active, vocal, which I appreciate, senior constituency. We hear from them. Most recently, I have some very vocal seniors who love their aqua aerobics and their aquatics program at Jesse Owens Park, and are pissed that, you know, a year ago, the board voted to increase their fees. And so we're working very hard to make sure that seniors still have the opportunity in their own community to engage in these public spaces like public pools and have the opportunity for fellowship. You know, when my mother was going to her aqua aerobics class, you know, half the time I think she would do some arm circles for 5 minutes and then stop. But the point was, it was community for her. It was fellowship for her. When some of the sisters didn't show up, they started phoning and looking for them. And the same with her. If she didn't show up a day or two, folks were calling me. Your mom didn't show up. Is everything all right? It's community. And that fundamentally we all need and want in our lives. And so we are working to make sure that the seniors in the who call the second supervisorial district home continue to have that opportunity in a way in which they absolutely can access it and afford it. Rigo, Sarah, tell me if there's some other issues that you wanted me to touch bases on. What more can I do before we open it up for questions?
Sure. Well, that was a wonderful overview. I think giving a lot of really important themes that you're highlighting, and the importance of partnership across government with public-private partners, the importance of responsive, person-centered governing. And I love what you said about really listening, and the Promotortis model that I hope expands to, you know, that we see more older adults being able to utilize, because I think there's a lot of benefit to that. And the importance of leadership. It's your leadership, it's the LA County leadership that's helping to move forward with initiatives such as Purposeful Aging Los Angeles. But, one question that we had when we were thinking through, how to best utilize the wonderful advice that you can provide us is, we know that policymakers at the state and local level face so many daunting challenges. We saw this with COVID. There were more problems than there was time to resolve it. There are problems that's, cross all populations, but we've particularly seen how they impact in COVID older adults, particularly Black, Latino, Indigenous populations who were among the hardest hit. And it really showed a lot of the health disparities and inequities in our system.
Absolutely. That existed before COVID.
Exactly.
And COVID simply ripped the bandage off.
Exactly.
So the world could see how people have been living all along. I agree with
That's
that.
right. And so what we're struggling with is, in a way, it was an opportunity because, as you said, it was able to really shine a light on these issues. The challenge this community has faced for several years is how to ensure that we can advocate most successfully as advocates for older adults in the aging population. There are so many challenging, pressing issues. We often feel that our issues aren't always rising to the top. For just as a whole, this year was we had some really tremendous opportunities this year. But what can we do moving forward to ensure that this voice is heard very clearly and that the priorities and policies needed are addressed at the state and local level?
I think the fact that we've gotten to the point where the state now has a master plan for aging, that the county is establishing a department, and your continued support and advocacy, serving on various boards and commissions, and in helping the new director of the Department of Aging kind of frame and prioritize issues for LA County. What we don't want to have happen is for someone to walk into that position and be a deer in the headlights and overwhelmed by all of the issues. And sometimes, having been, I think, an advocate still longer than I have been an elected in my life. And even when that shift changes, I am an activist policymaker. That's just my constitution and my makeup. Sometimes we have to have our family meetings about how we prioritize and acknowledge that we're not going to get it all done at once. We're just not. And some of those are the hardest conversations where we have to close the door and say, we know that it's 20 issues that are critical. What are the top 3 or top 5, whatever the magic number is, that we are going to push and all come together on and agree is going to be our priority? I think that's the most effective tool for advocacy. Because frankly, you don't give policymakers wiggle room and a way out. It's easy for us to say, well, one group tells me this, one group tells me that. You all go back and, prioritize and then let me know. But when you come to us initially, these are the 3. There's no room for us to pivot. We have got to address those 3. That's kind of, the secret. I know we're being recorded, but that's the secret I will share with you in terms of what I think is effective advocacy. We are asking for these 3. When I was an advocate, when I was the chair of the Legislative Black Caucus in the legislature, I said, colleagues, we're going to go to the administration with 3 budget priorities. If we spread our ass too far, fast and wide, we empower them to pick the priorities.
That's right.
But if we come with 3 and say we are holding you accountable for 3, there's no negotiation, there it is. So I hope that at the county level, we're able to come together. It will be then my job to make sure that the department is appropriately resourced to be able to respond, to deliver on those priorities that you've brought forward. That's the strategy that I have found over not only my career as an elected, but my longer career as an advocate, that's most effective.
Yep, that is so helpful. And I think I love this term, the family meeting. So I think all of our homework collectively is to have family meetings and say, okay, we're going to do this hard work. It's so hard to prioritize and to focus. But as you said, if you bring 20 different items to a policymaker, they're just going to pick which one they think is most important. Right. And you might not be as impactful.
And it might be the easiest.
Right.
right?
right.
Or the least expensive. But then we can say, you brought me this list, I delivered. Another example, maybe even more powerful, is the Legislative Women's Caucus. You know, when I first got to the legislature, they had cut $1 billion out of subsidized childcare. And there are so many priorities for the Women's Caucus, you can only imagine. And most of my 10 years there, the Women's Caucus said, we will make childcare our singular budget priority. Some of you got mad at us over that. I get it. But by making that tough decision and focusing, over a few years, we got that $1 billion back in subsidized childcare. And so it's that focused, dogged ask that I have found works.
Great, that's super helpful. And appreciate that so much. So one other theme that I want to highlight, and then we have a couple of important questions coming from the audience, is, you know, with these, I don't think ever in the history of aging services in California, we've faced a situation where there is such opportunity as we see right now with the influx of new resources. Granted, many of them are one time, but the Home and Community-Based Services Spending Plan resources from the Federal American Rescue Plan Act, new budget investments from the state budget, as some of which you referenced, you know, the new opportunities to better integrate services through the CalAIM program, recognizing social determinants of health as healthcare. This is a really watershed moment for aging services.
Yes, it's revolutionary.
Yes, it is. But this is our question. How can we ensure, like, when the money flows down to the local level, some of the challenges are that the money is being distributed through different departments, different funding streams, right? Different stakeholder processes. What are your thoughts on how the oversight and implementation of these resources can be best coordinated so that we know that the resources are meeting the target population that they're intended for and those who are most in need?
So that's the $1 billion question. And government is a bureaucracy and isn't always perfect. However, because this is a watershed moment, you know, we at the county level are using a new frame and lens of equity. We know that there has been, you know, systemic issues that have led to uneven investment across populations and across geography. And like I said, we pulled the blinders off, COVID pulled the blinders off, and we all saw the disproportionate impact. And so it's up to all of us to stay true to our vision and commitment around equity, around investments. And as we talked about the demographics, the populations of seniors, you know, it is clear to me that when we use this equity lens and equity framework, our aging population will come to the top. That's what I talked about. 60% of the senior population in LA County are people of color, are living in communities of color. And those are the communities and populations that must receive a disproportionate investment given the disproportionate pain and suffering they have experienced over time. And so it's a matter of discipline. We have set up the infrastructure here in LA County, us holding departments accountable for using this new lens and framework by which they do their own budgeting and do their own resource allocation. This first year may be bumpy, but we're setting up measurements. We're holding department heads accountable to get it done through this new lens.
Great. That is really a tremendous opportunity, I think, to have some accountability to ensure that the resources go to those who it's intended to.
Yes.
So we have a couple of questions related to one of, I think, the most pressing issues facing the service delivery system and the population, which is related to workforce, both in terms of training, but also in terms of access to qualified, culturally competent workforce. In particularly, I want to note the in-home supportive services program. We have a really great question from Greg Thompson with the Personal Assistance Services Council, who talks about the shortage of IHSS providers and the real problem that the IHSS recipients are having in retaining the providers. And, you know, he mentions a 2016 study that was done by LA County that showed that one out of five recipients lost their provider. And a 2019 report by the California auditor found that 65,000 recipients were unable to find a home care worker. So he is hoping that IHSS will be included in the new Department of Aging and Disability, but also would love any thoughts you have on how we address these significant challenges right now with workforce, and then a follow-up question about training.
So I don't know if IHSS will be included in the Department of Aging. That's I've made a note of your question. We'll follow up and find out. That's why I was so thrilled to hear the president broaden the definition of infrastructure. And his intent to include childcare and IHSS workers in that infrastructure. You know, the field has been inconsistent, and the field is suffering, as is childcare. Because of decisions the government has made. We haven't been consistent. And so people don't feel that it's a industry in which they can rely on and earn a livable wage, quite frankly. And so when we cut the programs, when we cut recipient hours, you know, people have shifted and gone on into other professions where they can make more and rely on the continuity and consistency of their pay. These are That's hard work. Care for our elders and care for our children is hard work that we claim we value, but then we don't show it in our treatment of the workers in that industry. Largely female dominated, let's be clear, largely low income, women of color, quite frankly, who find themselves in those sectors. And we don't value them as workers. We're gonna have a family meeting and I'm gonna tell the truth. We don't value them. And so including them in the infrastructure bill, providing some continuity in terms of the work and pay is what's really most important. And I hope the infrastructure bill passes. I think, again, even just considering their work as a part of the broader definition of infrastructure is a good first step. And then we all have to do our part. Not sure if they'll be included. And again, he references I'm not sure who posed the question, references a 2016 study. This was a decline we began to see pre-COVID. And right. I would attribute it to state budget cuts to IHSS, 5-6 years prior to the 2016 study, when the state was broke. And we severely cut eligibility hours for recipients as a cost savings measure. I remember those budget hearings like it was yesterday, Sarah, some of the most painful experiences I have had as a policymaker. When recipients came forward in Budget Subcommittee 3 that I chaired and said, Assembly Member Mitchell at that time, you tell me which 8 hours of the day you would suggest I not have care. Should I wait till noon for someone to come and help me get out of bed and feed me breakfast? Should I not have overnight care and not have my tube cleared? You tell me which 8 or 9 hours I shouldn't have access to. Hey, Greg Thompson, I see you. Those were tough years for all of us. And it's those decisions that then have a ripple effect over the years. So of course, when their hours were cut to workers, they had to go find other jobs and other ways of making a living. So that's the ripple effect of those policy decisions that we experience over time. So again, with the additional resources, with this reframing of how we characterize and reference this kind of work, I think is important.
Yeah, let's hope that it makes a significant difference. And just want to echo some of the comments that we've gotten. Thank you and for noting the value and dignity of this work and the importance of compensating this workforce for the tremendous work that they do. I want to make sure to, but before you have to leave, I think you know Phyllis Willis, and she has a question about, highlighting the importance of grassroots and innovative solutions, and with every problem being an opportunity. The question is how advocates can work with you to increase access to evidence-based health programs that would improve diabetes care and other chronic conditions for very low income African Americans, Asian Americans, and Latinos with low health literacy and barriers to services such as barriers to transportation.
Well, Phyllis, that is certainly a leading question. And Sarah, you'll appreciate this answer, having been a fellow. You could call Yolanda Vera in my office, my senior health deputy, and share those ideas with her, find out what we're doing in our office, the motions that we pass, and kind of our focus. But the short answer is reach out to Yolanda. It's probably Vera, VERA, at BOS, as in Board of Supervisors, .lacounty.gov, to talk to her about your ideas. And I hope you know my legislative history in advocating for just those kinds of programs.
Mm-hmm. Great. That's super helpful. Thank you. I think the staff are often the key to bringing ideas forward. So
always,
very
always.
Much. Yes. There is a great question here from Dr. Schickadance, who is geriatrician and the chair of the geriatrics workforce committee for LA County. And she's curious about the integration of budget priorities across silos. For example, how can Promotora's model be applied to the Care First Jails Last or in partnership with community-based programs such as chronic disease self-management and aqua aerobics? How does all of that get coordinated? Great
question, because we always, pardon me, bitch and complain about silos in government, but silos are everywhere. Silos are in philanthropic funding. And so, quite frankly, the CARES funding infusion, the ARA funding, and our new equity lens has given us the opportunity to think differently about how these programs are funded. Just, quite frankly, the ARA funding have more belts and suspenders than the CARES funding did. But the population we're talking about and the structural institutions that we're trying to break through and kind of cross-fertilize, we can with the ARA funding because they've all been COVID impacted. And so, this new infusion of federal dollars really gives us the opportunity to think differently about how we're funding. And department heads are clear about the board's priorities, through the initiatives we've passed, the anti-racist, the Women and Girls Initiative, the poverty alleviation initiatives, these initiatives that function at the board level that all departments have some accountability to, create opportunities to force them to have different kinds of conversations. Again, the creation of the new Department of Aging, that new leader will now kind of have the bully pulpit to reach out to his or her counterparts across county departments and be seen as an equal. So I think all of those are ways in which we are really going to get to the intersectionality of our lives. I'm so thrilled that CalAIM is finally going to come to fruition. We were working on that, forever. The vision around CalAIM goes back to my work at Western Center on Law and Poverty 20 years ago. And so we're getting there. Federal government's getting it. They're making resources available with fewer restrictions that allow us to fund programs that really meet the need of real people, because it's not just one department that meets all of my needs. I have a bunch of needs that a variety of departments can feed into.
Yep, absolutely. So I think that a lot of what you're saying, what I'm hearing is that now is the time to think innovatively, to build partnerships across populations. Why can't the aging advocacy community start building partnerships with other populations that serve, say, working families, and then come forward with proposals right now to try and to test these sorts of models of promotoras across populations. So thank you, Dr. Schickadance, for that question. Anyone who has other questions for Supervisor Mitchell, please enter it now.
I see Greg has his hand up.
Greg has his hand up. It sounds like Supervisor Mitchell would love to hear from you, Greg Thompson.
Thank you so much. It's great to see you again.
It's good to see you, my friend. We've gotten into a lot of good trouble together over the years.
Yes, we have. I will, in the interest of time, be really quick. My three specific asks would be that one, LA County addresses the provider shortage that I mentioned. Of the 240,000 IHSS consumers, over 60% are seniors. If IHSS, the whole department doesn't go into this new department, I would hope that you would consider registry services, because we deal with the 30% of people on IHSS who need to find a provider, who don't have family members. Some of them struggle. And I think LA County needs to really look at the registry service and invest in registry services. So provider shortage, PASC in the registry in the new department, and then LA County invest in registry services. And I thank you so much for taking my questions.
It's good to see you. It's good to see you. I'm sorry, Sarah, I didn't mean to
No, that's fine. That's fine.
Jump the line, but like I said,
absolutely.
Greg and I have history, goes back
That's
many years.
right.
We got into a lot of good trouble. So Greg, reach out. Because what I appreciate is that Greg is the kind of advocate that not only will identify a problem for me, but will help identify a solution that he thinks works. So Greg, we'll have a conversation.
That's another great advocacy tool, is focus, 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 and bring the solution. So,
yes.
But I know you're going to have to leave soon, but we have a wonderful panel that's going to be following you. And you heard from one of them, Dr. Heather Schickendance, but I want to see if Reggie Tucker-Seeley or if Barbara McClendon with the Alzheimer's Association has a question. Dr. Tucker-Seeley is with Health Zero and vice president there. And I wanted to see if he wanted to ask a question of you before we leave.
Thank you so much, Supervisor Mitchell. This has been an excellent discussion. So I am Vice President of Health Equity at Zero, the end of prostate cancer. And so as you know, there are substantial disparities, racial and ethnic disparities in prostate cancer, specifically for Black men.
Yes.
And I was really glad to hear you talk about sort of adding the equity lens to the policy process, but I know that can be challenging to sustain. In particular, sort of, thinking about health equity and racial disparities as not a special topic, but something that needs to be infused throughout the entire process. So can you talk to us a little bit about how to ensure that our policymakers do not get equity fatigue? That is, they get tired of talking about these issues, and that we can encourage our advocates to sort of hold your feet to the fire to ensure that lens gets consistently applied, not just in the policy development process, but also through policy implementation.
So Reggie, I can't ensure anything.
Yeah.
All I can do is tell you that we are working to set up this infrastructure.
Yep.
The other piece is around transparency, is the efforts we put into place and working collaboratively with the CEO to create a more transparent budgeting process, to empower you all to view the process in real time and hold us accountable if we fall short.
Yeah.
I have said repeatedly that, if I had a nickel for every time a policymaker uses the term equity, I could fund these programs personally, right?
Yes.
And also defining equity. I ran across a powerful visual that I have used, that my staff have used, and we've put it everywhere, where it's, ironically, people looking over a fence at a baseball game, go Dodgers, and, the different size boxes people stand on. So the littlest viewer is on the tallest box to get her head over that same fence. So it's not equality, it's equity, where we have to invest more in areas and populations and communities, as Secretary Yolanda Richardson beautifully coined the term for me, for hardly reached communities. We like to say hard to reach, as if it's their responsibility or problem. She's like, no, we have hardly reached out to them. And so that's what equity is, and continuing to have the conversation. And it's the discipline. It's the discipline that, when we see our way, I'm knocking on wood, through this current wave of COVID, that we stay true to this commitment for systemic change over
Yes.
time. So I
Mhm.
can't promise you, Reggie, or ensure it.
Yep.
Just know that these are the conversations I'm continuing to have. I hope they are
Yes.
the conversations you all will continue to have. And so it is my job to create the tools and opportunities for you all to be able to see what we're doing, transparency, be
Mhm.
engaged, so you can then hold us accountable. That's
Great.
that promise I can make, but I'm gonna keep trying.
Yes.
Wonderful.
you.
That's a terrific message. And I think that we all play a role in ensuring too that the commitment to equity doesn't stop after, a limited amount of time, that we keep pressing forward with it. So
Right.
thank you for that. So do you have time for one more question?
One more.
Supervisor Michelle? Okay, great. So I want to turn to Barbara
Sarah, can I?
McLendon.
Thank you.
Yes.
Hi.
I was going to say, yes, Barbara.
Thank you, Supervisor Mitchell.
Barbara was like, she is not getting off this Zoom without me asking my question.
That's why I'm an advocate, Supervisor
That's
Mitchell. I am right there. I'm a fellow spirit animal.
I'm not mad at you, Barbara. I'm not mad at you.
So just as Reggie was talking about an equity lens, so I work for Alzheimer's Los Angeles, local organization, 40 years working with families dealing with Alzheimer's and other forms of dementia. I want to encourage you to also use a dementia lens, especially as we're setting up this new Department of Aging, because while there is a lot of overlap with the broader aging community and the disability community, there are also special challenges and considerations for people who are living with cognitive impairment and for those that care for them. I also believe if we create a dementia-friendly world, a dementia-friendly healthcare system, that's a healthcare system and a world that actually works better for everybody.
I would agree.
And so I think as we see our numbers rise and the need for services to support these families just continues to grow, I'm hoping that you, and I know you have fellow champions on the Board of Supervisors on this issue of Alzheimer's and dementia, just keep that lens at the ready as well as you're making those decisions.
That's a very good point. And I learned years ago from a very young advocate at some convening. I don't remember where we were, but I'll never forget her face, and her point was that if we build systems to meet the neediest among us, they are better systems that serve everybody. And so the dementia lens, you've given me food for thought. You've given me food for thought.
Thank you.
Right.
And you may hear your words repeated as we go about the process of interviewing and looking for a new director for this department. So thank you for that.
Well, I want to take this time to thank you, Supervisor Mitchell. You have been tremendous in the words of wisdom you've given all of us, the importance of family meetings, the importance of prioritizing, the importance of focusing and developing clear messages, and committing to equity on the advocacy front as well.
I appreciate that. And Sarah, I hope I still have the same youthful glow and exuberance
sure
I had
do.
when you met me all those years ago.
You absolutely do. And you have now.
That's important to me since I just had a birthday last month and I'm fast approaching the population we are talking about providing services to. So thank you for lying to me, Sarah. I
Well,
appreciate that.
no, you keep up the amazing work you do, and we're so pleased to have you here. I'm sorry, was somebody trying to say something?
Oh, I was just going to say, this is Phyllis Willis. I can't let you go without thanking your staff. Kawami, I think I spoke to everyone there, getting to know your new staff. I knew your staff as a senator, so it really was a pleasure. And I want you to know that they were prompt, they responded quickly. We had late nights, but you're here. So just thank them. You have a great staff, so thank you.
I appreciate you for that. That's very important. Thank you.
Thank you for your tremendous work, and we look forward to seeing more of you in the months and years ahead. So thank you.
I look forward to that, and I hope you'll invite me back. Have a great rest of your session.
Thank you.
Thank you very much.
Okay, well, thank you everybody for that amazing discussion with Supervisor Mitchell. And now I'm really pleased that we have this opportunity to turn to a very esteemed panel for their reflections on some of the issues that rose up and to engage in discussion with all of you. So with that, I'd like to welcome Barbara McLendon, who is Director of Public Policy at Alzheimer's Los Angeles. Dr. Heather Schickadance, who is geriatrician and chair of the Department of Family Medicine at Harbor UCLA. And she also serves as chair of the geriatric work group for the LA County Department of Health. And finally, I'd like to welcome Dr. Reggie Tucker-Seeley, who is Vice President of Health Equity at Zero, the End of Prostate Cancer. But before we begin, I kind of wanted to take us back to this lens, which is our focus of today's discussion, which is to examine goal 2 of the Master Plan for Aging, which is, as Rigo said earlier, Health Reimagined. Essentially, the overall goal of this component of the Master Plan for Aging is to close the equity gap and address health disparities so that Californians can age with dignity and independence. The goal focuses on increasing and coordinating access to services in the home and the community, fostering healthy environments to promote healthy aging, expanding access to geriatric care and a culturally competent workforce, and fostering innovation in California's nursing homes. As we discussed earlier, it was really tragic that the COVID-19 pandemic shined a light on the tremendous health disparities and systemic racism and what it can do to a person over a lifetime, because we saw disproportionate deaths by Latinos, Blacks, Native Hawaiian, and other Pacific Islander adults who were over the age of 60. So today's discussion provides an important opportunity to consider the MPA goals in light of the challenges faced by older adults living in Los Angeles County. Where are the opportunities to build off the master plan, and what can the LA Aging Advocacy Coalition do to advance this work? So what I'm going to do now is I'm going to start with a specific question to each of our panelists that considers their experience in aging, equity, and advocacy. And again, as I said, please type your questions in the chat because we'd love to hear from you, as we have about a little over a half hour left. So I want to start with Dr. Shikadance. As chair of both the Department of Family Medicine at Harbor UCLA and LA County Health Geriatrics Work Group, you have seen firsthand the health equity issues that arose in COVID-19, particularly those that impacted the Black, Latino, and Indigenous populations. So Dr. Shikadance, what is your vision for how to ensure that we have a system that's culturally responsive, age-friendly, and that this can be the norm rather than the exception? And how might we address the barriers that impact marginalized communities?
Thank you so much. And I have to apologize for my voice, everybody. I'm getting over a cold and I have laryngitis. So thank you for bearing with me. I'm really honored to be on this panel and to share some of my experiences. As you heard, I do provide geriatrics care, both inpatient and outpatient at Harbor UCLA. I also do home visits. And I just wanted to share a story because I think that the home visits really lend, we've been talking a lot about lenses on equity, lenses of, being aware and appreciative of the challenges of caring for somebody with dementia or having dementia. And I just want to say that for me, if I were to have like my 3 wishes and really be able to focus on those throughout my career, they would be on helping sustain and support caregivers, family caregivers, and in the cases that there are not family caregivers available, really competent, compassionate, community-based caregivers. So similar to a promotoras model, I believe that empowering and accompanying communities to train and capacitate their own workforce, building wealth within the community, and a recognition of what the services and supports and the village has to offer. I think that is tremendously important. The workforce obviously starts, in the home, in the community, but across all sectors, we need more of a trained and compassionate, and I'm going to keep saying compassionate, workforce for older adults. As a geriatrician, I've worked up in the Harbor UCLA area for the past 3 years. But before that, I was at all of UCLA in the San Fernando Valley. And having the juxtaposition of caring for older adults and their families in the San Fernando Valley foothills, where people quite honestly would ride horses up around all of you, to the congested urban environment in the South Bay, the common thread is that all of those families had difficulty finding a geriatrician or anybody with any expertise in dementia, in the chronic conditions affecting older adults. And I really want to highlight my second ask, advanced care planning. What does it mean to have a culturally responsive, linguistically concordant, and ideally racially concordant person guiding and educating and supporting families and patients as they go through a process of advanced care planning? That's been something very highlighted by the COVID-19 pandemic. And I won't get on my soapbox about advanced care planning and how important it is. But I think that would be another wish that I have, is that we keep that in mind, that advanced care planning is a process. It should not be taking place at the end of life. It should not be taking place in the ICU or in the emergency room, where I had the witness trauma of seeing my own patients and their family members estranged from them because of COVID-19, facing these very difficult decisions for the very first time. And then I would say that the next thing that I really feel strongly about is a recognition of the life course. So we tend to focus on older adults as if this is a snapshot, and here we are. But actually, as all of us know from having our own family members and our work, I think many of us here, I probably am preaching to the choir, but for me, Health Reimagined is really understanding the life course and acknowledging the traumas and the resiliences and the strengths of the life course. How do we do that in healthcare? I mean, I have a 15-minute visit. That is the system, unfortunately. But how do we build a team that can acknowledge and address issues of the life course? And I'll say specifically ACEs, as an example, adverse childhood experiences. We've now been able to see that those have an independent association with risk of dementia, believe it or not. So as a family physician, I've known this all along. I've felt this all along as a family physician geriatrician, that the experiences that we have, even intergenerational differences of how the structures of society, the inequity of society impact certain communities and certain people, has ripple effects. And I think Supervisor Mitchell also alluded to this. So I don't know what this looks like in my wildest dreams. I don't know how Health Reimagined really incorporates an appreciation and a responsiveness to the life course that we have in front of us with, an individual patient, a family, a community. But for me, that is tremendously important. And I really look forward to integration of these budget priorities and initiatives that will, I think, with the lens of equity, start to understand and address life course experiences of our older adults.
Great. That is super insightful. And I love the theme of integration. And it's not just integration of the budget silos, it's integration of populations. Aging doesn't begin when you turn 60 or 65. As you said, ACEs Aware is not just a child's issue, it's an older adult's issue, because they bring those traumatic experiences with them throughout their life, and it impacts their ability to age successfully. That's why I think the state is really trying to put a lens on the master plan for aging, that aging is about community. It's not just about people over a certain age. It's all of us, and it impacts the whole community. And we all have a responsibility, as you said, to try and think more holistically about it, supporting caregivers, recognizing the importance of advanced care planning, and acknowledging the whole life course. So thank you so much for that. And Dr. Tucker-Seeley, this reminds me a lot of, kind of some of the themes you've raised about the importance of social determinants of health. And I know you've worked extensively on projects that address health equity and the intersection of public health, healthcare delivery, and aging research and practice. The Master Plan for Aging's Equity Work Group was tasked with ensuring that equity is fully baked into the master plan. And you talked a bit about this with Supervisor Mitchell, but I would like to hear what you think about what it means to have equity at the center of policy development and in the implementation of the master plan. And how can this help eliminate these health disparities and systemic racism?
Thank you for that question, and I'm really hopeful after this discussion and Supervisor Mitchell's um, responses, specifically her focus on two key components, and that is one is the definition of terms, so making sure that we sort of know what these terms mean, and then being explicit about the process. That is that we can see how we move from health equity to the implementation of a health equity policy, and that we're explicit about the decision-making process. So health equity is generally something that is very aspirational. So that is health equity means that everyone has a fair and just opportunity to be as healthy as possible. And to do that, we're going to have to remove obstacles such as poverty, discrimination, the consequences of those things, like the lack of access to good jobs with fair pay, education and housing, safe environments, and access to good health care. And no one agency can do all of those things. And so how do we move from this aspiration to implementation? And so one of the things that Supervisor Mitchell mentioned was, having these family meetings where we have to come to the table and say we have to prioritize, because there are so many areas for us to focus on, and the importance in that prioritization process is that it is explicit, that we see that prioritization process so that we know why our group may or may not be the group that's focused on in the first round of asks. So it might be the second round of asks that our issue is there. So, but centering equity in policy development means that the experiences of historically excluded groups, marginalized groups, which usually means minoritized groups, so racial and ethnic minorities, are centered. So when I used to teach courses, I used to teach a course on aging and social policy at the Leonard Davis School of Gerontology, and I would consistently ask my students, how does this policy impact different groups? Is there the potential for a differential impact? That is, how might this policy impact women? How might this policy impact people with disabilities? How might this policy impact racial and ethnic minorities, the oldest old? And then how about folks at the intersection of those identities? And so thinking through those processes for differential impact is a way to center equity. Now, for policy implementation, this means including mechanisms for the collection of data across multiple groups. So that is for the range of demographic characteristics. And we saw the struggle of this during the COVID pandemic when we didn't have the data across demographic groups, so that then the disparities can be measured. If we don't have the data, then we don't know those differences exist, because then it's hard to determine the size of the difference, and also how do we prioritize based on the size of that difference. It's also challenging here because this is going to require an intersectoral collaboration. And that intersectoral collaboration is going to require bringing multiple sectors to the table, keeping them at the table, and ensuring that health equity is at the center. And one of the challenges here is sort of the history um, of of racism sort of in the United States, which is also going to be a part of the process. And it's a bit related to the question I asked around equity fatigue, because we have to make sure that this is not a special issue or sort of a niche issue or something that we're talking about now because COVID has sort of uncovered or highlighted these disparities. And I'd like to just read a little quote that a colleague of mine, Dr. Zinzi Bailey, in a New England Journal of Medicine article, where she stated that structural racism reaches back to the beginnings of US history, stretches across its institutions and economy, and dwells within our culture. Its durability contributes to the perception that Black disadvantage is intrinsic, permanent, and therefore normal. Now, while the histories are different for different racial and ethnic groups, the notion that their disadvantage is intrinsic and normal is similar. So as we are having this health equity lens, we have to also sort of look within ourselves in the policy process to ensure that we are not applying the notion that the groups that are experiencing these disadvantages, that those disadvantages and those disparities are no longer tolerable, that it is not intrinsic and normal that those experiences are present. And I think with that frame, that helps to ensure that the health equity lens is sustainable.
That is a wonderful reflection of it, and kind of taking Supervisor Mitchell's comments even further. And I think a lot of important themes to consider in terms, particularly something that we hadn't talked about much yet, which is the importance of data collection. And you can't identify a problem if you don't have the data to support it, and you can't measure progress without the data too. So I think that has to be part of the key component to ensuring equity and addressing health disparities. And also the importance of intersectoral collaboration, which is hard, but it's more impactful if we can figure out how to advocate and do it together. So Barbara, I think Alzheimer's is really being recognized as an equity issue, something that really struck me is that the California Department of Public Health, they just released their updated facts and figures related to Californians with Alzheimer's disease. And the data really are startling. It found that between 2019 and 2040, the population of California will expand by 16%, but the population of people living with Alzheimer's will expand by 127%. And in particular, if you look at the at different populations that are are impacted most, if you look at the Latino population, the number of people living with Alzheimer's will more than triple, and it will nearly triple for for African-American Black population. And for the API population, the number of those with Alzheimer's will more than double. So these demographic projections carry such significant implications for workforce preparedness, for cultural competency, for supporting family caregivers, for how people actually finance the care they need. And in your role as public policy director for Alzheimer's LA, you have seen the intersection of these issues as they impact communities and families. And you also have a sense of where the policy opportunities might be. So with that, how would you frame a reimagined health system for people with cognitive impairment? And what would it take for us to get there?
Mm-hmm. Fortunately, we actually know a lot about what the system should look like for people who are living with a cognitive impairment and for their family caregivers. And there has been some progress in shifting our systems to get us closer to what that ought to look like. But the answer to your question is, some of it starts with an acknowledgement of the situation. So Reggie, back to your comment about we need data. We need data, even though California did just release an updated data report, we need really local data. So what's actually happening here in LA County? We do back of the envelopes about prevalence for Alzheimer's and dementia. It'd be great to have something more than my back of the envelope calculations when we do our advocacy work, so that we can really understand who in our community and what parts of our community are impacted by Alzheimer's and dementia, and who is providing care. And even there, sometimes families and people don't even identify themselves as caregivers. So if you ask them if they're a family caregiver, they might say no, when to us looking in from the outside, they absolutely are a family caregiver. So education has to happen both at an individual level and at a family system level, and then throughout that entire healthcare system. So I think training has come up several times through our conversation today, and we need to have that kind of system-wide training about Alzheimer's and dementia and what it means for families, so that in an ideal world, well, Heather, I'm gonna build on something you said earlier about ACEs aware. In an ideal world, we aren't just talking about Alzheimer's and dementia when it shows up. We're actually looking much further back, and my organization actually has a Healthy Brain Initiative that we're rolling out right now, where we're saying to people in their 30s and their 40s, look, I don't know when research is going to produce the silver bullet that's going to fix Alzheimer's disease, right? But what I do know today is there are many steps that people can take to reduce their risk. And that Now we get back to equity, because what are the things to do to reduce your risk? Well, that's eating well, that's having access to safe opportunities to exercise, that's managing your numbers throughout the course of your life. So that means you have access to the healthcare system. You have a doctor that you trust, maybe a doctor that is culturally competent, speaks your language, understands the community you come from, so that you feel that you can tell them what's going on with you, and you can receive what they're saying in a way that is actionable for you. And training in that system, so the doctor's actually asking these kinds of questions and doing the screenings. So something that the state has done is they're about to unroll a dementia aware program. So they are building on what was learned with that early adverse childhood screening program and pulling it forward into trying to do a better job of helping physicians be able to screen for Alzheimer's and dementia. So learnings are happening, and some of the silos are starting to break down, but we need to, obviously, from the statistics that you mentioned there, increase this pretty dramatically, because the need is significant and it's growing. And so back to just the person who's living their life and walking into that doctor's office, and in my dream world, they are getting those screenings regularly so that they can track what's happening with cognitive impairment, and simultaneously those conversations are happening with those family caregivers. So we are supporting them, we are assessing them, we are frankly documenting that they exist in the medical record, right? That doesn't even happen in many cases, because we know if you're living with a cognitive impairment and that family caregiver is not right there with that individual part of that care team, then whatever great recommendations you give that person, they're not going to happen, because it's that family caregiver who's going to make sure that these things are being done and addressed. And not everybody is ready or able to take on that role, certainly without some training about how you do some of this work with support, so they can continue to do it with access to respite care. Everything that I'm describing there might be available to you if you really know how to work the system, but it's probably not going to be easy for you to access. And the odds that it's going to be available in your community, delivered by somebody who's really understanding your community and who you are, those odds are even longer for you. So we need to do some investment in just frankly more money in the system so that services are more available. And that's been also a theme of our conversation today. Who are the workers who are providing this care? Are they trained? Who are the doctors? We don't have enough geriatricians. So we do have challenges there, but it is also a question of will. And that's maybe a little bit easier to be actionable on the front end. And by that, I mean, if I'm a healthcare provider or I'm the state of California, and again, fortunately, we're starting to see some traction here. Policies can be put in place that help to encourage the kinds of standard practices that we know need to be there. And so if we can put together the standard practices and holding people accountable to them, the resources being there to actually provide the services, and then again, making sure that this is all done in ways that connect to people's realities from the various communities they live in, then we can maybe come up with a system that actually supports people through this journey with Alzheimer's and dementia.
Oops, okay, there we go. It seems like there's a lot that, there's so many critical opportunities that we all see coming forward right now to do a lot of this cross-sectional work and really move forward on training and workforce development and investing in the systems that we need to really develop a more person-centered, holistic approach to service delivery. I would love to hear from you all about your thoughts as the state is looking at these tremendous opportunities that will be flowing down to the local level for system change. With all of you being connected to the Los Angeles Aging Advocacy Coalition, what are your thoughts on how to do some of what we've discussed today to prioritize, how to ensure that there is really strong advocacy and awareness of the different initiatives and where they are as they're getting implemented at the local levels, to keep that equity lens on it? One of the challenges I've heard from across the state from different people is that it's amazing to have all these opportunities, but there are so many, and there's all the same people at the local level working on all of the same advocates essentially working across the system. How can we ensure that there is representation in all of these different sectors where all of these conversations are going on? And how can LAAAC as a coalition best position itself? Any thoughts on that?
Okay, I'll start. I think this needs to be just the first of a lot of conversations. So I do hope that this isn't just a one and done. We've reimagined health today in 90 minutes. That instead what we've identified is some opportunities, which Supervisor Mitchell pointed out to us. And I think this new County Department of Aging is really critical, right? So we need to be sure that we are communicating as that agency is stood up, so that that happens in a way that is strategic. And there are obviously lots of people in our community who have ideas about what should be in that agency and should not be in that agency. But I do see that agency as a real point of leverage that we need to make sure we maximize. And so I don't know if what kind of a convening might be possible at the county level, but some sort of a mechanism, and perhaps, you know, LAAAC can be a driver of that, so that we can make sure that the right people are at the table and that those conversations are happening. And I just couldn't agree more with Supervisor Mitchell's admonition to us to get focused. And there are a lot of really wonderful things that are happening and a lot of very critical needs, but we really do need to decide for ourselves what those priorities should be, or somebody else is going to make that choice for us, and we might not be happy with what they decide.
So a big family meeting is needed.
Yep.
And it might be several meetings. And I think with that, it's developing the criteria. I know Dr. Tucker-Seeley, you talked about having equity baked in throughout, but really being specific and intentional about what that means in identifying the priorities.
Yes.
So any thoughts to that?
Yeah, and I think here again, I will discuss the importance of having the data and highlighting where we don't have the data, and being louder voices on the need to create whatever, if we have to do more research. I'm as a former academic, I'm always sort of writing papers, and we always say, you know, we need more research on this, or policymakers should do this, and oftentimes those are, you know, can be pretty glib statements that we make. But I think in this context, really highlighting where the data gaps are and encouraging either the researchers or, you know, community partners to work with us to get that data. I know that there was a report in 2015 that was a healthy aging report, but there was really no plan for, you know, sustaining or sort of creating that report again. So I know that the Los Angeles Alliance for Community Health and Aging, I've been working with that group to create a healthy aging data dashboard for Los Angeles County, because we need to have that data at the local level to inform the decisions that are made in the family meeting that Supervisor Mitchell mentioned. Because as you come to the table, you're going to want to have data across groups so that you can calculate the disparity. But then, when is a disparity actionable is often the question that gets asked. And so setting up, being explicit about that decision-making process, but then also having a framework for prioritizing where you're going to intervene. And to do that, you need to have the data across all the groups that are, across all the socio-demographic groups, so that then you can begin to address those problems.
Fantastic points. And I do want to note, you know, the Master Plan for Aging does have its data dashboard for aging, and it's a huge step forward. And the state is the first to also note that it still has a lot of room to be developed further. And I think it's going to be iterative, but this is a huge opportunity to do exactly what you're talking about. So I think a lot of resources will continue to be needed to build out those sources and to ensure that the local levels can also extrapolate the information so they understand their own gaps at the local level. I also want to note that there is an opportunity through the Home and Community-Based Services spending plan. The State Department of Healthcare Services is going to be undergoing a long-term services and supports data transparency initiative, where they're trying to compile data from across LTSS programs and put it into a usable format so that we can understand where the gaps are, what does utilization and expenditure look like? But ultimately, my hope is that we can see how are these services meeting the needs of people in California. It's not clear exactly what this will look like, but I think, again, this is where stakeholder engagement is so critical. We'll be hearing more about it once these funds get formally approved by the federal government as part of the spending plan. But this will have tremendous opportunity, I think, to build off, the data that we currently have and hopefully identify ways to continue growing it. So,
and key questions to ask there as folks are engaging in that process would be, how are disparities being defined and measured in those data sources?
Absolutely. Thank you for that. Phyllis Willis has a great question about training and how it's so important to understand racial equity and generational chronic disease in low-income neighborhoods. So her question is, how do we begin to collect data from these groups in a culturally responsive manner and train those who do not traditionally address these neighborhoods with the understanding that one size does not fit all?
That is a great question, and my response is going to be related to the discussion that we're also having in healthcare delivery around trust. So how do we engage these communities to be a part of the research process and to get the data that's necessary to answer these questions? So what we're saying about healthcare systems and healthcare institutions around trust is that they need to prove themselves to be trustworthy. They need to be trustworthy in terms of the care that they are providing. And as researchers, and as the research enterprise, we also need to be more, or the researchers, now that I'm working for a no longer in my academic role, we also need to be trustworthy. We also need to ensure that folks from the communities in which we want to do research have equal voices in the research process. Oftentimes researchers come to the table and they impose the research questions, they go into communities, they gather the data, and then they leave. So that's generally called helicopter research. And what we don't want to have happen is for more helicopter research. We need to have around that table to ask the questions that are relevant for the communities that Phyllis is mentioning. They need to be equal partners in the research. And that might mean that the question that the researcher had in mind might not necessarily be the most important question to the folks in those communities. And so we as researchers have to answer those questions first, and then moving to the questions that the researcher might have in mind. I think that helps us get the data. That helps us, one, to be culturally responsive because we're answering the questions that those communities want answered, but then they're also engaged in the process from beginning to end, from developing of the research question to the dissemination of the findings. Individuals from those communities are at the table. I think that is critical to being able to engage and to have the research in those communities to begin to answer some of the questions that they want answered.
Thank you so much. Heather, or Dr. Schickadance, did you want to add to that?
Yeah, I did. I mean, I think that is so key. And I just wanted to liken it to the process of advanced care planning. It's like, this is not a one and done. This is a conversation over time around alignment of preferences and priorities with care and services. That is my definition of advanced care planning. And I liken it to discussing the COVID-19 vaccine with people for whom there is mistrust and there is vaccine hesitancy. And I also use it as an example here. You know, I think it really does apply because, as Dr. Tucker Seeley said, it's about trust and trustworthiness. And if you try to come in and move so quickly and talk so fancily about an issue that the community, frankly, that is not what matters most to them. And it is not in a language or in a mode that is accessible to them, why would they? So I think that partnerships, and Dr. Willis has, a long track record of working in the communities and developing the trust and the partnerships so that they feel that we truly believe as researchers that they know best. And that it's a relationship and a conversation over time. So I just wanted to bring in my kind of like geriatrician advanced care planning analogy.
Yeah.
If it works for you guys, that's how I think about it.
Oh, absolutely. I think it applies across all of these different instances. So I'm aware of the fact that we have about 5 minutes, and I'd love to turn to each of you to say, what is one word that comes to mind when you think of today's conversation, and what do you think it means for the path forward right now? So who wants to start?
I'll start again, because then I get to pick among all the words. I am almost surprised to say that the word that comes to my mind is hopeful.
Yeah.
Sometimes it's hard to feel that way when you work in Los Angeles County. We are so big and so complicated, and we look around at what other counties have done and we think, oh, they did that. Why couldn't we do that? And then it's so hard here. But I'm hearing this incredible conversation and the comments that are coming in from people who are participating with us here today. And there are a lot of really smart people in this community. And we've got a Supervisor Mitchell, and I know others who are ready to partner with us here to actually make some change happen. So I am hopeful.
Great. Thank you. Good job, Barbara.
Yes, I'll go next. It's kind of 2 words, but it's hyphenated, so it's counted as one, and it's hardly reached. I really feel that, some of what Supervisor Mitchell repeated and really made a strong point about was that the folks in the communities and the neighborhoods, they need to be part of this conversation and not just thought of as a problem to solve. And so hardly reached, because here we're talking about policies and millions of dollars. And I think about a patient that I saw last week who was, being cared for by an intergenerational family in Cudahy and is, at end stage dementia. Like, I think of her and the hardly reached communities that we are trying so hard to reach and to, give their rights to care. And so that's the word that came to my mind.
Thank you for that. That's a great place to leave us. Dr. Tucker-Seeley.
For me, it's equity. I think after this past year and a half, where there were so many statements around systemic racism, health disparities, health equity, and many of those statements were performative, and nothing happened after the statement. And I think what Supervisor Mitchell laid out, I'm going to steal Barbara's word too, gave me a bit of hope, but that the equity lens was centered, and there's actually a plan, for ensuring that it stays. So equity for me is the thing that I'll take from this discussion today.
Great. Well, I've certainly learned a lot and benefited tremendously from hearing from all of you and from the great questions. Thank you all for being here. I don't know if Rigo, if you want to have any closing remarks, or if anybody else has any. Great.
Sure,
Rigo?
Sarah. Thank you so much for the opportunity to just express my gratitude to you, Sarah, starting with you. An incredible job today. Thank you so much for facilitating this wonderful conversation. And to our esteemed panelists, I thank you all for really bringing, and uplifting some very key issues to discuss today as we reimagine. I think not only health, obviously, I think we really had a broader conversation as issues that's transcending health and other areas, as well as we age. And I will leave with, certainly I don't have a particular word, Sarah, but I think sort of thinking about some points that I would like to sort of uplift as we end today. And what I certainly came across to me was the importance of holding these family meetings, coming together. But as was mentioned, nothing about us without us. So we have to make sure in those family meetings that we include those populations, communities that we are talking about and addressing. I also, I think picked up on, we need to be clear about what our priorities are and what our solutions are as well. We need to be focused. We just can't come in scattershot and have all these different things when we come into when we're advocating on specific issues. We also have to be clear about defining what do we mean, so we're all on the same page about equity. What does that mean to all of us? And being clear that we're talking about the same thing. And I also, heard Dr. Tucker Seeley about being explicit, and I think that is so important. That was part of conversations that we also had when we were establishing the master plan for aging through our equity work group. It's about, we need to be explicit. We need to be clear about which populations, which communities are we talking about. And particularly also being very sensitive and understanding of those intersections among the various communities as well. And also that, we're in this together. Aging impacts all communities. It's not just those 60 plus, or my case, 55 plus, right? But it's really all of us. It starts when we're born, and it's all sort of interconnected. And I think we need to reframe the issue of aging as not just for older people, but it's all of us together. So I think this has been an amazing conversation. And again, I want to thank you all. I want to thank also the planners of this event. And I think, so we'll end there. I think we have a roadmap that was very clear, that was provided by the supervisor, and how we think about how we organize ourselves and the pathway forward in working with them. And this is a time like no other. I've been in this field now for 30 years, and I don't remember a time where there's so many opportunities now to strike, particularly in Los Angeles County. We're all aware that we have a new department that's being formed. And I think there's so many opportunities to really achieve all these points that we've talked about family meetings, et cetera, et cetera. So I look forward as a member of this organization, LAAAC, St. Barnabas Senior Services, to continue this conversation with all of you. I hope that you will stay engaged, excited, and so that we together can be empowered to make a difference. So thank you all. Again, thank you, Sarah. I tip my hat to you for a wonderful conversation, and to all of you, the panelists again. Thank you, and be well, and have a great rest of your day.